This is an overview of an article entitled Healthcare Utilization and Patients' Perspectives After Receiving a Positive Genetic Test for Familial Hypercholesterolemia, a Pilot Study, published in the August 2018 issue of Circulation, Genomic and Precision Medicine. Hypercholesterolemia affects 30% of adults in the United States. Some of these individuals will have unidentified familial hypercholesterolemia, or FH. FH is an autosomal dominant disorder caused by variants in the LDLR, ApoB, and PCSK9 genes. The major clinical manifestation of FH is significant lifelong elevations in low-density lipoprotein cholesterol, or LDLC, which puts patients at increased risk of early-onset myocardial infarction and stroke. FH is currently underdiagnosed because of the overlap in presentation with non-genetic causes of hypercholesterolemia. Genetic testing for FH-causing variants can help identify individuals with this disorder. However, only 10% of individuals are aware of their diagnosis. Unrecognized FH leads to undertreatment and inadequate disease control. Commonly, statin monotherapy in individuals with FH will not reduce LDL-C to recommended goals. Therefore, combination therapy with additional lipid-lowering drugs such as ezetimibe, bile acid sequestrants, niacin, or PCSK9 inhibitors is required. However, it's estimated that only half of individuals with FH receive appropriate treatment with lipid-lowering therapies, and about a quarter of those achieve their LDL-C goals. As population-based genomic screening becomes more common among healthcare systems, more individuals will be identified and diagnosed with FH. However, patients' perceptions upon receiving positive FH test results from a population screening initiative and barriers to care, or how care is delivered, after receiving an incidental test result has not been fully explored. In 2008, the Geisinger Health System launched an initiative called MyCode, which includes biobanking of samples and whole exome sequencing. Patients were recontacted if they had a clinically actionable result as defined by American College of Medical Genetics and Genomics criteria. In the paper under discussion, the authors describe clinical outcomes as ascertained by the electronic health records for 23 of the 28 MyCode participants who had a positive genetic test result for FH. Furthermore, 7 of these patients participated in semi-structured interviews. This table shows the results of the genetic testing. Of the 23 individuals included in the study, 10 individuals had a missense variant in ApoB as their cause of FH, while the remainder had variants in LDLR. In reviewing the electronic health records for the 23 individuals, 83% had hyperlipidemia, 48% had coronary atherosclerosis, and 35% had peripheral vascular disease documented in their problem lists. 13 of the 23 had FH documented on their problem lists after receipt of the genetic test results, while only 5 individuals had an FH diagnosis on their problem lists prior to receipt of the genetic test results. 7 individuals had a history of myocardial infarction or cerebral vascular disease. The figure on the right describes how patients followed up with the healthcare system after receiving the positive FH genetic test results. 19 of 23 had documentation in the electronic health record that the FH genetic test result was discussed with a healthcare professional. 8 individuals, or 42%, discussed this specific genetic result with a clinical genomics specialist, either a geneticist or genetic counselor. 5 individuals discussed it with their primary care provider, 3 with a cardiologist, and 3 with a pharmacist. This slide summarizes the changes to care and clinical outcomes for the 23 individuals that received a positive FH test. After learning their results, 9 individuals had changes made to their treatment regimens, including 4 individuals who had increases in statin intensity or dose, 4 individuals who were prescribed an additional lipid-lowering drug, and 1 individual initiated on new therapy. Overall, 18 individuals were prescribed lipid-lowering therapy. Nonetheless, the overall LDL-C levels in this group of individuals were not substantially improved during the study period, nor was achievement of LDL-C goals. 7 individuals agreed to participate in semi-structured interviews about their experience receiving positive FH genetic test results. 2 individuals felt learning about their genetic results provided an answer. 3 were not surprised, and of those 3, 2 reported that learning this did not trouble them. All individuals reported that they felt they were already being treated for their high cholesterol. As part of the MyCode process, all genetic test results are first returned to a patient's primary care provider of record, and then a week later to the patient by a MyCode team member. 5 individuals of the 7 interviewed reported discussing their results with their primary care providers. After discussing the results with their clinicians of choice, 5 individuals discussed certain concepts that reflected an understanding of FH. 1 individual explicitly expressed confusion and uncertainty for future medical care. There were several key findings of this study. First, the study found that while most individuals discussed their positive FH genetic test results with healthcare providers, only a few had changes to their treatment plans as a result of the genetic information. Second, most individuals in the study were already receiving treatment for high cholesterol and either continued or increased the intensity of treatment. However, most remained uncontrolled for their disease. Third, patients reporting that learning of their FH results was not surprising and important to know, but felt that they were already being treated for their high cholesterol, so no further action was needed. Together, these findings suggest that there's a lack of understanding about the distinction between having high cholesterol and having a diagnosis of FH. Future research in this area should be conducted to understand the reasons clinicians did not make changes to individuals' treatment plans after positive FH genetic test results were reported, and the impact of various potential solutions to help reduce the knowledge gap experienced by clinicians and patients about FH.